Good morning, good afternoon, good evening, wherever you're watching us from. This is the Tea Scientist. My good name is Granton Trevor Ouma, a licensed Medical Laboratory Technologist and an officer based in Kenya. Well, welcome to my video. Have you ever experienced symptoms like itchiness? Yes, itchiness. I said itchiness in your private parts. Have you ever experienced symptoms like discomfort during sex? Have you ever experienced a discharge from your private parts, especially that looks white to yellowish? For men, coming out of your urethra, your private parts in short. For women, the same. Well, this video is still for you. I'll give you a very detailed, well-explained, comprehensive, but simple to understand the disease. What am I talking about? Gonorrhea. You guessed it right. So, gonorrhea as a species, pathologically we have two species of gonorrhea. One of them is gonorrhea or Neisseria meningitis. All these bacteria cause different infections in the body. But specifically for today, we'll discuss about Neisseria gonorrhea, or scientifically Neisseria gonorrhoeae. So, for millennials, this disease has caused a lot of suffering to the humankind. For millennials. Think about before the advancements in medicine, when science now started being taken serious, the science part of medicine. Your private parts will be beaten very hard, especially for men. Be beaten to drain the pus out. Hiyo ni ungwana kweli. And then another thing, toxic mercury method of treatment being injected into your urethra used to happen around 16th centuries. In the 19th centuries is when they started using. Now the doctors back then, healers, used to flush hot water, extremely hot, at around 50 degrees Celsius into your urethra to flush out the pus, and maybe thinking they will kill the bacteria out. They never knew if it was a bacteria or a virus. There was no advancement in terms of medical back then. It was just trying to treat anything. Okay? Now, the turning point. What was the turning point in terms of the treatment of gonorrhea back then? Then there was this guy, a German physician called Albert Neisser. Albert Neisser used the newly advanced microscopic techniques to examine pus from a patient who was suffering from gonorrhea. And this marked the breakthrough, because for you to kill something, you need to understand it. Where is it coming from? How are you getting infected? And what are the virulence factors? Like, virulence factors are those factors that make a pathogen to cause a disease in a human being. Okay? Or whatever it is. So, he identified, looking at, when I talk about advanced microscopic techniques, this involves staining. And one of the basic stains back then was gram staining. So when you stain the pus, you'll be able to, the bacteria will pick up the stains, and you'll be able to see the exact bacteria after washing. Okay? Staining, then washing off. So all this happens in the lab. So what did Albert Neisser observe? So Albert Neisser saw a pair of bean shaped. This is how he described it. a pair of bean-shaped cells, which in modern day we refer to them as diplococcus, that caused the infection, of which it was later named after him, Neisseria gonorrhea, in his in his honor. So Albert, by the way, just to give you a history, Albert Neisser was nominated for a Nobel Peace Prize, but he never won it. I don't know why. Okay, maybe because it was coming from Germany, and you know back then in Germany shit was going down. So knowing the exact enemy paved the way to targeted treatment, and then they started using antiseptics like colloidals, silver, and then eventually discovery of the sulfur drugs, sulfonamides. So when
No! God, please, no! No! No!
sulfonamides drugs were discovered, we started using those drugs to treat Neisseria gonorrhea, of which it was effective. But over the decades, this disease started developing resistance due to poor use or misuse of antibiotics. So penicillin, Neisseria gonorrhea developed resistance against penicillin, and we know right now, due to the advancement in science, medical science, we have one strain that we have isolated called penicillase producing Neisseria gonorrhea, which is very resistant. It is called PPNG in short, a very resistant form of strain of gonorrhea, very dangerous. So, to continue, in the 1940s, then is when what I just talked about, that penicillin revolutionized treatments after its discovery. That's when now doctors have had a definitive cure. But over the years, like I've said, these bacteria started developing resistance. Is when right now what we are using for treatment is actually cephalosporin, which is the last of the options. So sahi ukienda hospitali, what will be injected? It's obvious, ceftriaxone. That's the only option. And then maybe due to other infections that can accompany gonorrhea, like chlamydia, you'll be also given doxycycline. Okay. So that was a lot of pure science and medicine. Now let's get to the story part of it. Yeah. I call it the ancient theory of the origin of the name. How, unajiuliza mbona inaitwa gonorrhea? Why? Like I was talking to my friend, and why is it called gonorrhea? Where did this name come from? Sasa acha nikupeleke back. Turudi nyuma kidogo. Sasa pale pale Greek, or you can call it Greece, modern day Greece, in the 130 AD, kulikuwa na jama fulani, that AD, that is after death of Christ. Kulikuwa na jama fulani, a Greek physician called Galen. So Galen, during that time, there were no advancement in terms of medicine. Treatment was clinical. You observe how a patient behaves, you try to treat clinically, you treat symptoms. So this guy, depending on his observations and the obvious symptoms of gonorrhea, so these people suffering from gonorrhea used to have pus, especially for men, used to have white to yellowish pus coming out of their urethra, like their private parts. So Galen tried to call it linguistically, to name it linguistically, depending on how it the pus came out. So Galen used to think that this was semen, that this was involuntary semen production from men's private parts, and he called it the seed, flow of seed, but in their language. Now, flow of seed, the gonos in Greek means seed. Then ear means flow. So it was called flow of seed, but in Greek it was gonorrhea. Okay, that was in 130 AD, before after death of Christ. But and other physicians, of course, they described it. That was the name of the name they gave to that disease by then. And mistakenly, they never knew it was actually a bacteria. And that, I think, that is why they used to treat it the way they used to treat it, brutally, and a lot of suffering. If you had gonorrhea back then, it meant suffering, a lot of suffering for you. Kupigwa marungu kwa private parts, kutoa hiyo pass, ama udungwe toxic mercury. Do you know how toxic mercury is to your body? It was crazy. Ama udungwe maji moto kwa mjulus. For lack of a better word. Maji ya, your body is optimally at 37 degrees. So imagine maji ukiboil. Like you maji yenye umeboilingi, like iko, let's say, boiling point of water is around 100 degrees. Pure water, that is pure water. So imagine divide that by 2. Alafu hiyo ndo unadungwa kwa urethra, and you know how painful it is. Iko kunywe maji moto ama uji moto. Una ka feeling, si ndio? So imagine feeling that in your urethra. It's crazy. So that is just one story. Another story was, before Galen's description or naming, Hippocrates, who lived between 460 to 370 BC, had described this disease unknowingly, but he described it as a symptom, because what he said was difficulty in urination. Okay? And what Hippocrates called this disease was venous pleasure. A pleasure of Venus, which literally means indulging in too much sex. Okay? So this disease was associated mostly in brothels, because back then we also had brothels. So unajua Jesus alikuwa na roll na Mary Magdalene pale hivyo. Unajua tu unatambua Mary Magdalene. Si unatambua Mary Magdalene alikuwa anafanya nini? Si alikuwa na brothel. So back then kulikuwa na hizo shit ka hizo. So pleasure of Venus was too much, so what Hippocrates called it was indulging too much in pleasure of Venus. Okay? And then there's another name also. Now, the clap. So, the clap was a name given to it. It was just a slang name, you know. Back then, people gonna say, umechanuka kiasi. Like, slang, they used to talk slang. Like, so the slang language for this disease, like venye sahi mnaita kaswede in Kenya, there was a slang name for it back then. Na ilikuwa inaitwa the clap. So this clap, according to my research, ilikuwa na two origins. So one of the origin was French word clapius. Clapius. So clapius in French inamaanisha a brothel. Is a word to describe a brothel where the deceased normally spread. And then the second origin, the clap, was derived from the way how brutal how the bizarre way of treatment was for the deceased back then. Juu wase wangepigwa mjulus, ama umwagiwe udungwe maji moto, ama your penis would be put in between woodboards. Ipigwe hivi. It's like you're clapping to force the pass out. Maze, ilikuwa ni mbaya jo. Ilikuwa ni mbaya. Sasa that was just a story. Let's now want to discuss now the science part of it. So, the science part of gonorrhea is it's not that complicated after making the discovery. You know, something that you don't know usually sounds to be very difficult to understand or something, but it's the most easiest, and I believe even everyone who is watching this video will understand, because I'm going to talk about it in the simplest manner as much as possible. So we'll start by describing the morphology, because wewe umekuja hospitali, you are feeling, you have back pain, like you are presenting normal symptoms as a UTI. You have a back pain, and then you have itchiness in your private parts, painful urination, you feel pain during sex, that irritation, okay? You have a discharge that is whitish to yellowish, okay? Both men and female. But unaingia OC, you are sent to the lab, and you're not sent to the lab for a specific thing. Mostly, you know, itatumwa tu go do urinalysis. That's the test that is requested. You come to the lab, I will give you a container to get me your urine, and I'll tell you exactly what to get. Do not collect the first urine, but the midstream, ile ya katikati ndo nilete, because of kind of contamination during the first stream. At least itoke sufficient. I'll do a test. I'll do the chemistry of your urine, check for leukocytes, if you have blood, check your pH, the pH of your urine, check if you have nitrites, yes, if you have passes, that is leukocytes, you have glucose, have protein in your urine which should not be there, urobilinogen, bilinogen. I'll check all those, and then do a microscopy now, like Albert laser. I'll take spin your urine, now take the deposits, go put on a slide and cover slip it, and go to a microscope, and keenly observe, get a good focus, and then move to a power 40, keenly observe whatever is there. So at this stage, I'll see their bacterial cells, if there is any, okay? And especially these will only be effective for men who are producing pus, not women. Is the routine lab works, let's say like urinalysis and HVS, they are not that reliable in detecting Neisseria in women. So for men, they are very reliable. That is the first that you see it. But at this point, when I'm doing a urinalysis, I'll not be able to tell if this is Neisseria gonorrhea. I'll just recommend there. You do a culture, or you do gram stain. You do a urethral swab, we do a gram stain. Because with a gram stain, I'll be able to detect the gonorrhea. Or we do a culture, and then we grow the bacteria, and then we do antimicrobial sensitivity test. We get to know which drug specifically works for you. But for gonorrhea treatment, the treatment is so obvious. So I'll give you a report. You go back to the doctor or clinician that you went for consultation. Your report has pulses, maybe blood, protein, leukocytes in the chemistry, of course. The obvious thing will be treated is an UTI immediately. But you find cases which I've observed, patients complaining of recurrent UTIs, but you have been recommending, you as a lab professional, you have been recommending every now and then for this certain patient to do extra tests. Sometimes we understand maybe due to financial constraints, they are not able, but also you doing a blind treatment is more expensive because this patient will keep coming, or will keep coming for the same case, or they keep going buying drugs that are not really helping, and in fact you are inducing antimicrobial resistance in this patient, because the more you give them different antibiotics that they don't really need, is the more you are introducing antimicrobial resistance. And this is what we are trying to be stewards. So morphologically, if a test like high vaginal swab or urethral swab has been requested for a patient, like make it so obvious for you, now I'm talking to clinicians, make it so obvious for you to request, as you request a urinalysis, also request for a high vaginal swab or a urethral swab, so that at least it becomes easier for you to get a good picture, to get answers from the lab. So what will a high vaginal swab, let me call it HVS or urethral swab, do? So I'll prepare a wet prep, check just to see an overview what is there under microscope. Then I'll do a gram stain. So what you see now is what I'm going to talk about morphologically. So Neisseria has a very distinct morphology, this bacteria. One, this bacteria is gram negative. Gram negative means it appears as pink, reddish under a microscope. Second, this bacteria is cocci. Cocci, that is a scientific word for a circle, but is not just a circle. They occur as double, as described by Albert Neisser. He saw a bean shaped, two bean shapes, a pair of bean shapes. So we call it diplococci, like diplococci. It is diplococci now in science. Okay, and these, if you use a more advanced microscope, you'll be able to see the pili. The bacteria has pili, like they look like filaments, but they are not filaments or flagella, they are pili. they're smaller. Let's discuss now culture. I've done the preliminary. So morphologically, doing a HVS gram stain. Gram stain is just a preliminary process in the laboratory to give preliminary reports. We have not, but you can still diagnose at that stage if it is a man. But a woman, because of the clinically from the sites, clinical sites, there's a lot of loading of normoflora. So you will not be able, the sample can easily be contaminated. Okay. Yeah. So for culture and culture characteristics, so Neisseria gonorrhea, it is an aerobe, but can also grow in a little bit of an aerobic environment, like it grows well in oxygenated environments, and then it is a fastidious organism, meaning it is very hard to grow. It's very hard to grow in the lab. It requires very specific conditions, like lazima uibembeleze. But the funny thing, it grows so well inside you guys' bodies.
Oh no! That one there was a violation. Personally, I wouldn't have it. And if you do just
another thing, the optimum temperature is between 35 to 36 degrees Celsius. That is during incubation. And then the pH of the media. So there are things we use to culture bacteria in the lab. We call them medium. So medium are they are nutrients, actually, added nutrients, like that support the growth of a certain microbe. So we call them media. So the media's pH should be between 7.2 to 7.6. And then it is also essential to add CO2, carbon dioxide, which should be between 5 to 10%, which is very hard. You can see those conditions. It's very hard. So let's talk about the medias, because we're talking about culture. So in terms of media, we have non-selective and selective media. So one of the non-selective, let's talk about non-selective medias. So for non-selective medias, one of them we have chocolate agar. So it will grow on chocolate agar, but chocolate agar, other microbes can also grow. So it's you can get colonies. Colonies are just bacteria growing together, a specific of the same kind growing together, because bacteria, they when the cell divide. So let's say I inoculated only one cell, so that cell will divide until it makes a colony, like many of them around, they are together. Okay, that is what we call a colony. Another non-selective media is Muller-Hinton agar, which is a very basic media that we use like in every other culture, or cultures, like culture sample. When you're doing antimicrobial sensitivity test, that is media that we use like in every sample. Then we also have the modified NYC media. Okay, so currently we have, let's switch to the now selective media. We have the thiamartin media, which has antibiotics added to it, of which one of the antibiotics is vancomycin, listin. Another one is nystatin. So it is these antibiotics that make the media to be selective, because the addition of these antibiotics means depending on the clinical site, which is not sterile, because there are other microbes, the normal flora, they will not grow because of these antibiotics. Vancomycin, nystatin, colistatin, they will prevent the growth of these microbes. So only Neisseria gonorrhea will grow. That's why we refer to this media as a selective media. Okay, so umeculture pale, this is Kiswahili now. You have cultured you've taken a sample, cultured on this diamatine. They now use the selective media. You have stretched, then incubated. But Neisseria is a very fastidious organism. It struggles to grow. So it grows very slowly. So you give it time. It is growing, then it has grown. So what will you see on the media? What will be your observation? How will it grow? How does it grow? So, normally the colonies will be small. They will be round. They will be translucent. In terms of shape, they will be convex. And then the surface will be finely granulated, like finely granular, the surface. If I can remember, with some how do I describe this? With some lobate, like margin around the colony, like lobate, like a lobe. Yep. So after describing the colonies, what next do you do? Now you start the identification, because obviously you have to do the biochemical tests. Yes, for every bacteria that is isolated, you have to, for you to isolate a bacteria, you have to also do the biochemical tests. So one of the biochemical tests we do for these bacteria for gram-negatives is oxidase test, where Neisseria gonorrhea is oxidase positive. Okay? Yeah. And then Neisseria gonorrhea also ferments glucose but not maltose. Ferments glucose but not maltose. Yep. So pathogenicity, let's talk about something. Pathogenicity, like the ability of you acquiring that disease or getting these bacteria into your body. So I'll talk about two. So one is the source of infection. Now, in terms of source of infection, we have 2 points. I'll talk about 2 points there, because one, what makes this bacteria able to infect another person who is not infected? One of when we talk under the topic, the source of infection, is the ability for someone to be asymptotic. Like, say akona gonorrhea lakini hana any symptoms, bro. No symptoms kabisa, na konayo for the longest time. And these people are usually called the reservoirs or carriers, because they reserve that bacteria for the next person who wants to venture. Jamani. Venturing is good, but not always good. Oh. And the source of infection, under that topic again, we have the patients. Now, patients, anaweza kuwa akonayo na kuambi. For us, it is a patient. For you, it is a gaidi who doesn't want to tell you that he has the infection or he has or he or she has been diagnosed for that infection, hataki kukuambia. But for us, we see tunajua ni patient. Of course, that's why it is a must for you to do contact tracing when tukijua uko nayo. But kuna magaidi anajua uko nayo lakini hataki kuambia. You see, now that's a pathogenicity. That is increasing the pathogenicity for that bacteria to infect other people. You get? And then another thing is mode of infection. Yeah. Mode of infection. Mode of infection, because under mode of infection, we can talk about venereal and non-venereal infection. So under venereal infection, this is generally I'm saying sexual contact. So you remember your gaidi alipatikana na gonorrhea, alipatikana na kaswede, but hataki kuambia. Then shughuli inaendelea bro, shughuli unaendelea. You are being inoculated daily. You see, that's a problem. You are increasing the pathogenicity of this bacteria. Na maybe wewe siwe pekee shughuli unapewa. Unaget? Shughuli mnapewa shughuli mnapewa wengi. Yaani mko kimbogi. Na hiyo mbogi pia iko na mbogi ya. Kila mtu ako na mbogi yake. Na unajua wase pia wambogi wakuangi mbogi moja. Wakuangi kwa mbogi moja. Unapata huyu ako huko na ako huko na ako huko. Juu yeye ni mse wa mbogi. Makosa. Wewe ni mse tu wa mbogi. But makosa inakuja ukiintroduce watu wageni kwa mbogi na wewe uko na kaswede. That's the problem. Unaget? Yeah. And then non-venereal, we talk about during vaginal birth. So if a female has gonorrhea, they can pass it to the child during birth. Na it causes conjunctivitis. Like the baby gets their eyes infected, and if not addressed, it can lead to blindness. That's the bad thing of it. But that is so kinda innocent kupata, but that's why we are here. That's why the lab is here. And that's why I'm doing an awareness kind of presentation to you guys, like for you to understand why you need those tests. Ukikuja hosi, usione ni kama unatokwa do, ama like we are under business. It's to help you. Of course, there are some people who are after business, but kuna zile vitu basic, you know. When you come to the lab, please talk to the lab guy. I know we don't talk much because we only talk reports, but you find people who talk to us get the most out of us because we understand the process of a disease. And from your symptoms, I can actually tell what you are suffering from. Yes, and from the package of tests that have been requested, I'm able to tell which kind of infection the doctor thinks you have. Okay, I don't really need to communicate much to you. That's why you find most of the lab professions, lab officers and technologists don't talk much. Just look the list of the tests like this. Oh, I know what the doctor is questioning. But if you're somebody who, feel free to talk. And getting a diagnosis doesn't mean that is the correct diagnosis. always you have the right to question the kind of diagnosis that you are given. Ukirudi consultation room unaambiwa kuna hii, question the lab, muulize mbona nimepata na hii. Let them explain to you. Yes, if the clinician is lying to you, trying to sophisticate things, sometimes also tunaelewa. We cannot just give you a certain kind of information where we know we are able to treat you like without causing any massive social economical effect. We just brush through it, but always ask what is the lab saying, or come to the lab kama umepata mtu mwenye you cannot talk to or not willing to communicate. Sometimes people are also busy, either way in the lab ama consultation room. Just come to the lab, excuse yourself, just ask the person that attended to you, because it is your right. What have you seen? What is going on in my body? They should be able to explain to you according to the tests what you are suffering from. So let me talk about now we are done with pathogenicity. Now let's talk about now how the disease advances in your body. Now the pathology. Majina ni ngumu. Pathogenicity, now pathology. Now let's talk the pathophysiology. That's the correct word. Pathology, pathophysiology, the study. Pathophysiology. Now how does the disease occur in your body? So let's say niko na Kevo na Esther. For siko baya, just majina natumia as example. I have Kevin and I have Esther. So Esther akona kaswede. I'm using Esther because I'll explain at the end of the video why I'm using Esther as the reservoir. So Esther kona kaswede, Kevo ajui. Kevo ni newbie. So Kevo amepata deal which pendana nini, then wameenda kuhave fun. Okay, exchange tususu. So Kevo after 2 to 8 days anaanza kukuwa na involuntary semen production. Na si clear. In short, Kevo anaanza kuproduce pasa nyora. Ama ataka wametulia tu yeye pasi inatoka tu. All of a sudden Kevo ana change ngodha. Like Kevo tangu amwage bado anamwaga. Anaendelea kumwaga after hizo 2 to 8 days. Unashangaa rada na Kevo. Kevo kama kwenda osi. Pimo Kevo kuna gono. Alipata dokim fit. Na alienda lab akapata lab tech poa. Lakini Esther asikii shit. So Kevo anarudi kuambia Esther, wewe ulinipea kaswende. Esther anasema, aje, mimi si mgonjwa. Mimi sisikiangi hata kuumu. No check. So na Kevo alikuwa mwambiwa arudi na partner wake. Kevo kuchukua Esther akaenda osi. Kuchukuliwa high vaginal swab. Kapatikana pia konayo. Kevo ndo ulileta hii shit. Juu ndo umekuwa kwanza kugonjeka. Kevo anasema wewe ndo ulinipea. Usikii hivyo ndo wasee kutokana. just because of lack of understanding. Unaona? But how did this disease happen in Kevo and Esther? Why is it that Esther alipata kaswende but imu affect akonayo tu imetulia tu? I feel anything because she's an adult woman. No. So vulva hakuna vulva iko affected, bro. Hakuna. There's no infection in the vulva. Ko sawa kabisa. No. Ni risable. Hata urethritis bado. Yeah, ko sawa. But ukimfanya urinalysis utapata 2 passes plus 1 pale. You know. Yeah, ko sawa. Feel anything. But akosangi passes. Unasema ni normal. Hiyo ni normal for a woman. Kienda usina mbua yone. Labu wamepata passes but hii ni normal for a woman. A woman that is not pregnant. Okay. A certain level, yes. Kuna 0 to 2 is okay, 0 to 3. Either from 5 to something should open your eyes, you know. Order that HVS. So, let's go back to pathophysiology. Venye Kevo happen ku exchange to na Esther. So, Esther akona yeni reserve, akona hii gonorrhea. So, the bacteria was inoculated in his urethra. So, how does this bacteria affect Kevo? Na Kevo juu alikuwa mjanja alisema hiyo usiku hataki kunyora immediately after sex. Akasema yeye hataki kunyora, atanyora asubuhi. Gonorrhea was happy. Your night. Wote wali enjoy. Gonorrhea kuna kitu fulani nilisema inaitwa pili. So, these pili, the bacteria uses them to attach to the epithelial cells. So, when it attaches to the epithelial cells, inaanza kupenetrate through the intercellular spaces. Not intercellular spaces. To reach the subepithelial cells. Unaelewa? Ikisha ingia hapo bro, haitoki. Because it has attached to the subepithelial spaces, the immunity comes in. Your immune system ina kick in. Who is this, bro? Because your immunity has the ability to differentiate between self and unself. It will automatically attack this bacteria because it is not part of your body. So when it attacks, a lot of white blood cells will merge there. When they fight and they are losing, they die. Because normally it is a suicidal fight. Zikipigana zinakufa. Like, mina jiingiza bro. Mina jiingiza yote. Inakufa. So that is the pus that you experience. Like, if you're having gonorrhea, production of pus inatoka because they are trying to fight a war that they are not winning. Unaelewa? And it is a suicidal mission. It's either bacteria ikufe ama zikufe. Hakuna kurudi home. So unatoa passes. That's when you have now urethritis for both male and female. Kama ni macho, kama ni mtoto. If you the people who engage in oral sex, you get pharyngitis. For the eyes, you get conjunctivitis for children that are born through vagina na mama co-infected na gonorrhea. And also we have bacteremia. Now the bacteria now reaching, you see, when it is fighting, inaweza cause vidonda huko ndani, and then the bacteria gets into your bloodstream. And which kind of bacteremia means bacteria in your blood. These bacteria can even travel up to your brain barrier. Blood-brain barrier, and cause meningitis. meningitis, sepsis, all those, and it is very little.